Hello friends, today we are going to discuss about acute decompensated heart failure. So acute heart failure refers to the rapid or gradual onset of symptom or signs of heart failure severe enough for patient to seek urgent medical attention leading to unplanned hospital admission or an emergency department visit. Acute heart failure is the leading cause of hospitalization in subject aged more than 65 years and is associated with high mortality and rehospitalization rate. In-hospital mortality ranges from 4% to 11%. Post-discharge 1 year mortality can be 25 to 30% with up to more than 45% death or readmission rates. So clinical presentation of acute heart failure can be acute decompensated heart failure, acute pulmonary edema. It could be isolated right ventricular failure and patient can present as cardiogenic shock. So the main mechanism behind acute decompensated heart failure is LV dysfunction and sodium and water renal retention. And the main cause of symptom is basically because of fluid accumulation and increased intraventricular pressure. Main hemodynamic abnormalities are increased left ventricular end diastolic pressure, pulmonary capillary wedge pressure, low or normal cardiac output, normal or low systolic blood pressure. Then clinical presentation will be wet or warm or wet or cold. That is, the patient's peripheries will be cold, but pulmonary edema may be present, may not be present. And the main treatment will be diuretics, inotropic agent, vasopressor, and in advanced case, short-term mechanical circulatory system or RRT if needed. Then the next presentation is acute pulmonary edema. It is occurring because of the increased afterload or predominant LV diastolic dysfunction or any kind of valvular heart disease. So main cause of symptom is fluid redistribution to the lung, which results into the acute respiratory failure. So it results in the increased left ventricular end diastolic pressure and pulmonary capillary wedge pressure. So the patient will be warm or wet. The main treatment will be diuretics and vasodilator that we can start in the form of Lasix and nitroglycerin. Then the next presentation is isolated right ventricular failure, right ventricular dysfunction and or precapillary pulmonary hypertension. So main cause of symptom is increased central venous pressure or often systemic hyperfusion. So, and hemodynamic abnormality will be increased right ventricular end diastolic pressure, low cardiac output, and low systolic blood pressure. So, patient will be wet or cold. So, and treatment will be diuretics for the peripheral congestion, inotropic agent, and vasopressor, and short-term mechanical circulatory device or RRT if needed. And the patient can present with the cardiogenic shock. The main mechanism is severe cardiogenic dysfunction. The main cause of symptom is systemic hypoperfusion. The hemodynamic abnormality is left ventricular end diastolic pressure and pulmonary capillary wedge pressure. The other than this, patient's cardiac output will be low, systolic blood pressure will be low, patient will be wet or cold, and the treatment will be inotropic agent, vasopressor, short-term MCS, and RRT. So let's have a look on the diagnostic workup of new onset acute heart failure. If any patient is presenting with the new onset acute heart failure, then we have to start with the history. We have to look for the specific signs and the symptoms suspected of acute heart failure. Then we need to proceed with our investigations, which is in the form of ECG. We need to connect the patient to the pulse oximetry. Once it is diagnosed as a heart failure, then we need to do the echocardiography of the patient to know whether it is systolic or diastolic. Then we need to proceed with the initial lab investigation, chest X-ray, lung ultrasound, and other specific evaluation. And please measure natriuretic peptide level. If natriuretic, please remember this, if natriuretic peptide level is less than 100, then acute heart failure is ruled out. If natriuretic peptide is more than 100, then acute heart failure is confirmed and we need to go for the echocardiography to confirm whether it is systolic or diastolic. So this is the number of the diagnostic tests which are required in the patient with the acute heart failure, like ECG. So ECG basically we are doing for to rule out acute myocardial ischemia and arrhythmia. Then chest X-ray. The chest X-ray we are doing to rule out congestion and the lung infection. Lung ultrasound we are specifically looking for the B lines in the context of pulmonary in the heart failure. If the presence of B line is indicative of the pulmonary edema. Then echocardiography. Echocardiography will tell us about the cardiac dysfunction. It helps in telling about whether this cardiac dysfunction is systolic or diastolic. Then the pro-BNP. Pro-BNP actually is the diagnostic test and it is a gateway for doing the echocardiography. If our pro-BNP is elevated, then there is always possibility for the heart failure. But if our pro-BNP is negative, then we can confidently say there is a heart failure is not there. Then serum troponin. Serum troponin is to rule out about acute coronary syndrome. Then creat level is needed to rule out any renal dysfunction. Serum electrolytes are needed for the to diagnose electrolyte disorder, and iron status is very necessary because this anemia is one of the precipitating cause of for the heart failure. Then other similar to the iron profile, thyroid stimulating hormone and thyroid profile is necessary because hypo or hyperthyroidism is one of the etiology for acute heart failure. Then D-dimer if we are suspecting pulmonary embolism, PCT if we are suspecting the underlying causes infection, then lactate to know the severity of the shock, pulse oximetry and ABG to know the respiratory. Then about management. Regarding pre-hospital management, in the pre-hospital setting, acute heart failure patients should benefit from the non-invasive monitoring, including pulse oximetry, blood pressure, heart rate, respiratory rate, continuous ECG instituted within minutes of the patient contact and in the ambulance if possible. Oxygen therapy may be given based on the clinical judgment unless oxygen saturation is less than 90%, in which case it should be administered. In patient with respiratory rate of more than 25, oxygen saturation and if oxygen saturation is less than 90, then non-invasive ventilation should be initiated. Pre-hospital management should not delay the rapid transfer of acute heart failure patient to the most appropriate medical setting. Now regarding in-hospital management. Diagnostic workup and the appropriate pharmacological and non-pharmacological treatment must be started promptly and in parallel. Acute heart failure patients are triaged to the appropriate level of care according to the degree of hemodynamic instability and severity of the critical illness. The type and the intensity of in-hospital monitoring depends on clinical severity, setting of care, and in-hospital course. So the acute heart failure is the heterogeneous condition and management may differ according to the main clinical presentation. So the management starts with the search for the specific cause of acute heart failure. This includes acute coronary syndrome, hypertensive emergency, rapid arrhythmia, severe bradycardia, conduction disturbances, acute mechanical cause such as acute valvular regurgitation, acute pulmonary edema, uh, acute pulmonary embolism, infection, myocarditis, and tamponade. So after exclusion of all these conditions, we need to be treated or correctly corrected urgently. And the management of the acute heart failure differs according to the clinical presentation. So whenever the patient is presenting in your ER or in ICU, and if you are suspecting acute heart failure, then please, then the first job is to rule out whether this patient is in cardiogenic shock or not, or whether this patient is in severe respiratory distress or not. If the patient is in cardiogenic shock or the severe respiratory distress, then immediately we need to intubate this patient and start the appropriate pharmacological agent according to the condition. And we need to and we may need to proceed, or patient may need early mechanical circulatory device. But if it's not looking like, if the patient is comparatively stable, then our job and after the then And if we have stabilized our airway breathing circulation, then our next job is to find out the etiology of this heart failure. So the etiology of the heart failure is summarized into CHAMPIT, where C stands for acute coronary syndrome, H stands for hypertensive emergency, A stands for arrhythmias, M stands for mechanical cause, P stands for pulmonary embolism, I stands for infection, and T stands for temporal. So if it is if any of this condition is there, then we need to correct this cause to correct our acute heart failure. And if it is not, then we need to proceed with the further treatment. So the first line of therapy is oxygen therapy and the ventilatory support. In acute heart failure, oxygen should not be used routinely in non-hypoxemic patient as it causes vasoconstriction and reduction in the cardiac output. So oxygen therapy is recommended in patients with acute heart failure and saturation of less than 90%, PO2 of less than 60 to correct hypoxemia. In COPD, please remember to maintain the oxygen target level between 88 to 92 as hyperoxygenation may cause ventilation perfusion mismatch, suppress ventilation and leads to hypercapnia. So during oxygenation, please keep watch on ABG and SPO. Then about role of NI. Non-invasive positive pressure ventilation, either continuous positive airway pressure and pressure support, improves respiratory failure, increases oxygenation and pH, decreases the partial pressure of carbon dioxide and work of breathing. So, non-invasive positive pressure ventilation should be started as soon as possible in patient with respiratory distress. That is, if the respiratory rate is more than 25 breaths per minute and saturation of less than 90% to improve gas exchange and reduce the rate of intubation. Blood pressure should be monitored regularly during non-invasive positive pressure ventilation. So, any increase in intrathoracic pressure with NIV decreases venous return and right to left ventricular preload. It may also decrease the cardiac output and blood pressure and should therefore be used with caution in patients with reduced preload reserve and hypotension. The increased pulmonary vascular resistance and RV afterload may also be detrimental in RV dysfunction. So, intubation is recommended for progressive respiratory failure in spite of oxygen administration or NIV. Next line of treatment is diuretic. Intravenous diuretic are the cornerstone of acute heart failure treatment. They increases the renal excretion of salt and water and are indicated for treatment of fluid overload and congestion in the vast majority of acute heart failure patients. So the loop diuretic is commonly used due to their rapid onset of action and efficacy. No differences in the primary efficacy outcome of patient symptom and global assessment was shown with the high dose regimen compared with the low dose regimen. So we can according to the dose chart. So even if we start the loop diuretics with the high high dose, or even if we are starting the loop diuretics with the low dose, there is no difference. So, however, there is a great relief of dyspnea, change in the weight, and the net fluid loss if we start the patient with the high dose regimen. So, high diuretic dose may cause the greater neurohormonal activation and electrolyte abnormality and are often associated with the poor outcome. So, whenever you are starting the patient with the high diuretic dose, please keep watch on the sodium and the potassium. Because next day you will definitely find either sodium levels are high or potassium levels are low. So, if not needed, this a high diuretic dose can be de-escalated to the lower, means depend upon the patient's respiratory status and the urine output. So based on this observation, it may be appropriate when starting IV diuretic treatment to use low doses to assess diuretic response and then increase the dose that is insufficient. So whenever you are starting with the diuretic, it's recommended to start with the low dose and then gradually escalate, seeing the patient how patient is responding. So diuretic treatment should be started with an initial IV dose of furosemide or equivalent dose of bumetanide or torsemide corresponding to the 12 times the daily oral dose taken by a patient before admission. So if the patient was not on diuretic, starting dose of 20 to 40 mg of furosemide or bolus of 10 to 20 mg IV torsemide can be used. Furosemide can be given as 2 to 3 daily boluses or as a continuous infusion. Daily single bolus administration are discouraged because of the possibility of post-dosing sodium retention. With continuous infusion, loading dose may be used to achieve steady state early. Diuretic response should be evaluated shortly after start of diuretic therapy and may be assessed by performing spot urine sodium content measurement after 2 or 6 hours or by measuring hourly urine output. A satisfactory diuretic response can be defined as urine sodium content of more than 50 to 70 milliequivalent per liter at 2 hours or by urine output of more than 100 to 150 ml per hour during 6 hours. If there is insufficient diuretic response, the loop diuretic uh, IV dose can be doubled and with further assessment of diuretic response. So if the diuretic response is still inadequate, that is, if the patient is passing less than 100 ml per hour of diuresis despite doubling loop diuretic dose, then we need to think about administering other diuretic that is acting on the different side. So namely, we can add thiazide, metalazone, or acetazolamide. However, this combination requires careful monitoring of the serum electrolyte and renal function. Loop diuretic dose should be progressively decreased when significant negative fluid balance has been obtained. Transition to the oral treatment should be commenced when the patient's clinical condition is stable. It is recommended that after achievement of congestion relief, oral loop diuretic are continued at lowest dose possible to avoid congestion. So this is the management of diuretic therapy in patient with the acute heart failure. So if the patient is on oral loop diuretic, so we need to, first step is we need to see whether the patient is on oral loop diuretic or not. So if the patient is already on the loop diuretic and now this patient is presenting with the acute heart failure, then in starting only we need to start 1 to 2 times the daily dose of oral dose as a IV IV medicine. But if the patient is not on the loop diuretic, we can start with the normal dose of furosemide, that is 20 to 40 mg. Then to assess the response of the diuresis, we can measure the two things. So one is urine output and the other thing is urinary spot sodium. So urine output is comparatively easy to measure because normally in ICU patients are catheterized and if we are monitoring his urine output continuously for 6 hours and if it is more than 100 to 150, then we can say the patient is appropriately respond to our diuretic therapy. Then we need to check for the urine spot sodium after approximately 2 hours. If it is more than 50 to 70, then we can say our patient is appropriately respond to the diuretics. So rather than urine spot sodium, it is very much feasible to monitor urine output. So if we find that our patient is appropriately respond to the diuretics, then we need to repeat the similar dose every 12 hours. And we need to check again for the urinary spot sodium and the urine output. If the patient is not responding appropriately, then then it is recommended to double the IV dose till we are getting the appropriate response. So if we find the appropriate response, then continue that same dose until the complete decongestion. But if you are not finding the appropriate response, even after doubling the dose of loop diuretic, then it is recommended to add the other diuretic which is acting on the other side, like thiazides. And then we need to check for the serum creatinine and electrolytes every 24 hours. Now the next line of treatment is vasodilator. Intravenous vasodilators, namely nitrate or nitroprusside, dilate venous and the arterial vessel, leading to the reduction in the venous return to the heart, which leads into the less congestion, lower afterload, and increased stroke volume and consequent relief of the symptom. Nitrate act mainly on the peripheral vein, where nitroprusside is more a balanced arterial and venous dilate. So these IV vasodilators are maybe effective than diuretics in those patients whose acute pulmonary edema is caused by increased afterload and the fluid redistribution to the lung in the absence or with minimal fluid accumulation. So intravenous vasodilator is considered to relieve acute heart failure symptom when SBP is more than 110. They may be started at low dose and up titrated to achieve clinical improvement and BP control. And nitrates are generally administered with the initial bolus followed by continuous infusion. So the main role of this vasodilator in the acute heart failure is to reduce the afterload. So whenever we are seeing the patient of the acute heart failure, and if the blood pressure is more than 110, then by administering this vasodilator, uh, we can actually reduce the BP and we can also relieve the symptoms of the acute heart failure. Now, the care should also be taken to avoid hypotension due to excessive decrease in the preload and after. For this reason, there should be used with the extreme caution in patients with left ventricular hypertrophy and severe aortic stenosis. So, before starting with the this vasopressor, please check with the 2D echo whether the patient is having LVH or severe aortic stenosis or not. However, favorable effects are described in patients with the LV systolic dysfunction and aortic stenosis when vasodilators are given with the careful monitoring of the hemodynamic parameter. So even if the patient is having patient are presented with this left ventricular hypertrophy or severe aortic stenosis, but if our invasive lines are in situ and if our hemodynamics are in check, we can still make the use of this vasodilators. Now, the next line of therapy is inotropes. Inotropes are still needed for the patient with the low cardiac output and hypotension. They should be reserved for patient with LV systolic dysfunction, low cardiac output, and low systolic blood pressure, resulting in the poor organ function perfusion. However, they must be used with caution, starting at low doses and uptitrating them with close monitoring. So inotropes, especially with the adrenergic mechanism, can cause sinus tachycardia, increase ventricular rate in patients with atrial fibrillation, and may induce myocardial ischemia and arrhythmia, and increase mortality. Levosimendan and type 3 phosphodiesterase inhibitor may be preferred over dopamine for patient on beta blocker as they act through the independent mechanism. Excessive peripheral vasodilatation and hypotension are limitation of levosimendan and type 3 phosphodiesterase inhibitor. Now, the next line of therapy is vasopressin. Norepinephrine may be preferred in patients with severe hypotension. The aim is to increase perfusion to the vital organ. However, this is an expense of increased LV. Therefore, combination of the norepinephrine and inotropic agent may be considered, especially in patients with advanced heart failure and cardiogenic shock. So, the use of norepinephrine is the first choice compared with dopamine and epinephrine. Dopamine was compared with the norepinephrine as the first-line vasopressor therapy in patients with the shock and was associated with more arrhythmic event and greater mortality in patients with cardiogenic shock, but not in patients with hypovolemic and septic shock. So these are the number of inotropes and the vasopressors that are used to treat acute heart failure, like dobutamine, dopamine, mindrinone, enoximone, levosimendan, norepinephrine, and epinephrine. So please remember, so norepinephrine is the choice of vasopressor that we are using in cardiogenic shock patient or in acute heart failure. So in preferred than adrenaline and dopamine. So why? Because it is based on the finding of SOAP2 trial and Optima trial. It has been shown that dopamine and the adrenaline, they are more associated with tachyarrhythmia than the norepinephrine. So, and regarding inotropes, levosimendan we are not using nowadays. After publishment of the survival study, where they have found levosimendan is the adverse effect of levosimendan was more than the beneficial effect. But levosimendan is helpful in those patients who are already on the beta blocker. About dobutamine, yes, there is always worry about hypotension. So if the patient is hypotensive, do not use dobutamine. Then the next drug that we can use in the acute decompensated heart failure is opiate. Opiate relieves the dyspnea and anxiety. They may be used as the sedative agent during non-invasive positive pressure ventilation in improved patient adaptation. So dose-dependent side effects include nausea, hypotension, bradycardia, and respiratory depression. Morphine administration is associated with greater frequency of mechanical ventilation, prolonged hospitalization, and more intense admission and increased mortality. So opiates may be considered in selected patients, particularly in case of severe and intractable pain or anxiety and in setting of palliation. Now the next drug that can be used is digoxin. Digoxin should be considered in patients with atrial fibrillation with rapid ventricular rate despite the patient is on the beta blocker. It can be given in the bolus of 0.25 to 0.5 mg IV if not used previously. However, in patients with comorbidities like CKD or other factor affecting digoxin metabolites or the elderly, maintenance dose may be difficult to estimate theoretically and measurement of serum digoxin concentration should be performed. Now about thromboembolism prophylaxis. Thromboembolism prophylaxis can be given in the form of heparin or low molecular weight heparin, and the other anticoagulation is recommended unless contraindicated or unnecessary. Now about short-term mechanical circulatory device. In patient presenting with cardiogenic shock, short-term mechanical circulatory device may be necessary to augment cardiac output or support end organ perfusion. So this short-term mechanical circulatory device can be used as bridge to recovery, bridge to death, or bridge to death, or bridge to bridge. So the initial improvement in the cardiac output, BP, arterial lactate may be counterbalanced by significant complication. So high quality evidence regarding the outcome are remain scarce. So regarding VA ECMO, it may be considered in the fulminant myocarditis or other condition causing severe cardiogenic shock. So depending on the severity of myocardial dysfunction or concomitant mitral or aortic regurgitation, VA ECMO may increase LV afterload with increased LV end diastolic pressure and pulmonary congestion. In this case, the LV unloading is mandatory and can be achieved by means of transeptal and ventricular apex vent or adding unloading device such as Impera device. Now about we will summarize the all the recommendation for initial treatment of acute heart failure. So first treatment is oxygenation and ventilation support. Oxygenation is recommended in patient with saturation of less than 90%, PO2 of less than 60 mmHg to correct hypoxia. So this has class 1 recommendation level of evidence C. Intubation is recommended for progressive respiratory failure persisting in spite of oxygen administration or NI. Non-invasive positive pressure ventilation should be considered in patients with respiratory distress. That is, respiratory rate of more than 25 and saturation of less than 90, and started as soon as possible in order to decrease respiratory distress or reduce the rate of mechanical endotracheal intubation. Then about diuretics, intravenous loop diuretic is recommended for all patients with acute heart failure admitted with the signs and symptoms of fluid overload to improve symptoms. Combination of loop diuretics with thiazide type diuretic should be considered in patients with resistant edema who do not respond to increase in loop diuretic dose. About vasodilator, in patient with acute heart failure and systolic blood pressure of more than 110 mmHg, IV vasodilator may be considered as initial therapy to improve symptom and reduce congestion. About inotropic agent may be considered in patient with systolic blood pressure of less than 90 mmHg and evidence of hypoperfusion who do not respond to standard treatment, including fluid challenge, or to improve peripheral perfusion and maintain end organ function. So inotropic agents are not recommended routinely due to safety concern unless the patient has symptomatic hypotension and evidence of hypoperfusion. Now about vasopressor use. Vasopressor, preferably norepinephrine, may be considered in patients with cardiogenic shock to increase blood pressure and vital organ perfusion. Now about other drug therapy. Thromboembolism with prophylaxis, that is with low molecular weight heparin, is recommended in patients not already anticoagulated or with no contraindication to anticoagulation to reduce the risk of deep venous thrombosis and pulmonary embolism. Routine use of opioid is not recommended unless in selected patients with severe and intractable pain or anxiety. Now about recommendation of short-term mechanical circulatory support. Short-term mechanical circulatory support should be considered in a patient with cardiogenic shock as the bridge to recovery, then bridge to decision, and bridge to bridge. Further indications may include treatment of the cause of cardiogenic shock and long-term mechanical circulatory system and transplantation. So this intra-aortic balloon pump may be considered in patient with cardiogenic shock as bridging therapy, including treatment of the cause of cardiogenic shock or long-term mechanical circulatory system and transplantation. So IBP is not routinely recommended in post-MI cardiogenic shock patients. So, according to some articles, the IBP is only recommended if there is a presence of MR. And according to the SHOCK 2 trial, there is a no mortality benefit if you use the IBP as mechanical circulatory device over conservative therapy. Thank you, guys.